All right, let's jump right into a classic NCLEX safety scenario. Picture this. You have a patient who's been on Xanax every day for panic attacks, and they just decide to stop cold turkey. As their nurse, what is the number one most life-threatening thing you should be watching for? Seizures. Full stop. When you abruptly stop a benzodiazepine, especially a short-acting one like Xanax, you're essentially yanking the brakes off the brain. All that built-up electrical activity goes haywire, and that can lead to catastrophic, life-threatening seizures. This is a core safety concept you absolutely have to know. And that's exactly what we are going to nail down today. Welcome to The Explainer. We're diving deep with a high-yield safety review on one of the NCLEX's favorite topics, benzodiazepines. My goal is to get you so confident that you can handle any safety or prioritization question they throw at you. So here's our game plan. We'll start with the core mission, how these drugs actually work. Then we'll look at your benzo arsenal, because you've got to know your meds. After that, it's code red, the big dangers. We'll cover the nurse's safety protocol and wrap it all up with a final NCLEX pre-check to make sure this stuff sticks. Okay, first things first, to handle these drugs safely, you have to understand what they're actually doing inside the central nervous system. So benzodiazepines work by supercharging GABA, which is basically the brain's main chill-out neurotransmitter. Think of GABA as the brake pedal for your brain. Benzos come along and they don't stomp on the pedal themselves, but they make your foot press down way, way harder. This lets a flood of negative chloride ions into the neurons, which just shuts down the electrical firing. The bottom line, benzos calm the central nervous system a lot. And right here, this is the whole story for the NCLEX. This is the big paradox. The exact same mechanism that makes benzos so helpful, calming everything down, is also what makes them so dangerous. Yes, they calm anxiety, but they can also calm down the respiratory drive so much that your patient stops breathing. As the nurse, you're constantly walking that tightrope. So how does this play out on the floor? Well, not all benzos are created equal. You have a whole arsenal of them, and you have to know how to match the right drug to the right mission. Okay, this table is pure NCLEX gold, so listen up. For your short-acting benzos like alprazolam or Xanax, your brain needs to scream withdrawal risk. It hits fast and leaves fast, which is why stopping it is so dangerous. For your intermediate-acting ones, think lorazepam or Ativan. This is your go-to, your first-line choice for stopping a seizure that's happening right now, status epilepticus. And for the long-acting, diazepam or Valium, your number one thought should be elderly safety. This stuff hangs around forever in the body, building up and putting older adults at a huge risk for falls and confusion. Avoid it. Now for the specialists. When you see a patient in alcohol withdrawal, you should immediately think chlordiazepide or Librium. It's the gold standard. For procedural sedation, like before a colonoscopy, you'll see midazolam or Versed. It works great because it's fast and causes amnesia, but it's a potent respiratory depressant. Your priority is always airway, airway, airway. And what about a patient with a bad liver? Oh, the NCLEX loves this one. Just remember the LOT drugs, lorazepam, oxazepam, and temzepam. They're safer because they're metabolized differently, so they won't build up to toxic levels. All right, let's shift gears. We are now entering the most critical part of this review, the code red dangers. These are the complications that can kill your patient, and I guarantee you they will show up on your exam as priority questions. We started here for a reason, you guys. Withdrawal is not just about feeling bad. It's a full-blown medical emergency. It starts with anxiety and tremors, but it can quickly escalate to seizures. And remember, the risk is highest with those short-acting drugs like Xanax because of how fast they leave the body. This is why our number one patient teaching point is never stop these suddenly. It has to be a slow taper. So what do you do if your patient overdoses? The textbook answer is the antidote, Flumazenil. It works by literally kicking the benzo molecules off the GABA receptors, reversing the sedation. Sounds like a magic bullet, doesn't it? Well, here comes a massive NCLEX trap. And here is the trap. If you give Flumazenil to someone who is physically dependent on benzos, someone who's been taking them for a while, you will instantly throw them into severe withdrawal. And what does severe withdrawal cause? Seizures. The very thing you want to avoid. So Flumazenil is usually only for reversing sedation in a patient who's never taken benzos before, not for a chronic user. For most overdoses, your priority is supporting their airway and breathing. Okay, I need everyone to listen closely because this might be the single most important safety concept in this whole review. Benzos and opioids, two totally different classes of drugs that, when taken together, create a truly fatal synergy. Let's break it down. Benzos sedate you. Opioids kill your pain.
they have different antidotes. But look at that bottom row. They both hammer the respiratory center in your brain. When you combine them, the effect isn't 1 + 1 = 2, it's 1 + 1 = 10. It leads to profound respiratory depression, coma, and death. This is why your absolute top priority is to always check if your patient is on both.
So, knowing the risks is half the battle. Acting on them is the other half. Let's get practical and talk about your non-negotiable nursing safety protocol. This is your action plan. Think of this as your pre-flight checklist. Step 1. Before you even think about giving the med, get a baseline. What's the respiratory rate? How sleepy are they already? You can't spot a decline if you don't know where they started. Step 2. Check that med list for opioids and ask about alcohol. You have to prevent that deadly combo. Step 3. These drugs make people drowsy and unsteady on their feet. That means fall precautions are a must, especially for older patients. And step 4. Your job is not done after you give the pill. You have to go back and monitor. Check their breathing, check their O2 sat. And patient safety doesn't end when they leave the hospital. Your teaching has to be crystal clear. Here are the big ones. Number 1, do not stop this suddenly or you risk seizures. 2, avoid all alcohol, period. 3, no driving or using heavy machinery until you know for sure how this drug makes you feel. And 4, you need to call us immediately if you feel way too drowsy or dizzy because that could be a sign of toxicity. All right, you have the knowledge. Now let's lock it in. It's time to put it to the test with a final NCLEX pre-check and see how sharp your clinical judgment is. Let's run through the biggest traps you'll see. Trap number 1, missing those early signs of withdrawal, like anxiety and tremors, and not realizing it can escalate to seizures. Trap number 2, you see an order for lorazepam on a patient who's also getting morphine, and you just give it. No, you have to question that order. It's your job to be that safety net. And trap number 3, giving Valium to an 85-year-old without thinking about their massive fall risk. That's a direct threat to patient safety. Okay, here we go, a classic who do you see first question. You have 4 patients. Patient A is on a stable maintenance dose. Patient B is getting the right drug for their condition. But patient C, they just had a procedure with sedation and now have a pretty scary vital sign. So who are you running to see first? Think ABCs: airway, breathing, circulation. Who is actively unstable right now? It's C. It has to be C. A respiratory rate of 8 breaths per minute is an active, life-threatening emergency. That is respiratory depression from the Medella's lamb happening right in front of you. Patient A is stable, patient B is getting the expected treatment, patient C is circling the drain. On the NCLEX, airway and breathing will always be your top priority. So, as you head into your exam, I want you to burn this one phrase into your mind. Benzos calm the brain, but they will steal balance, memory, and most importantly, breath if we're not careful. If you can master that core conflict, you'll be ready for any benzo question the NCLEX can throw at you. You've got this.